Hi, I'm Kendrick Johnson with themedschool.com. I'm a third-year medical student at Toro University, Nevada, and today I'm going to talk a little bit about endocarditis. We're going to briefly cover the presentation, the diagnosis, and the treatment of infective endocarditis. So the classic presentation of endocarditis includes these immunologic manifestations where we have small emboli that are causing different problems around the body. So if you can picture vegetations on the heart valves kind of breaking off and causing small areas of ischemia or areas of abscess. So splinter hemorrhages, like you see in this picture of the fingernail, are just small hemorrhages in the fingernails. Osler's nodes and Janeway lesions are similar, but as the node implies, Osler's nodes are raised and generally painful, whereas Janeway lesions are not. So this picture here is supposed to be of Osler's nodes, but I think you could make an argument that those might be Janeway lesions. Roth spots are just a similar phenomenon, except they happen on the retina. So you're doing an eye exam and you see some small hemorrhages on the retina. And then the more concerning findings are when the septic emboli go to the brain, the kidney, the spleen. One of my patients had multiple emboli to his small bowel and had small bowel infarcts and had to have a lot of his bowel resected. Emboli to the brain, of course, can cause stroke. Emboli to the kidney, obviously kidney damage. So these are some pretty concerning findings. You can also end up with pulmonary embolism from these emboli. And we'll talk a little bit later about what that means to our treatment. So we have some criteria for the diagnosis of infective endocarditis. So if you have a positive blood culture with a common endocarditis organism plus an echocardiogram that's positive for vegetations, then you've got a diagnosis. That's two major criteria. If you only have one of those major criteria, then you need one of these minor criteria, which include presence of a predisposing condition, which might include rheumatic fever, or it could be some other valvular disease. Fever is another minor criteria. Embolic disease is another criteria. Immunologic phenomena, like the Roth spots or Osler's nodes we showed, and just any positive blood culture or a blood culture with a rare organism. So if you only have one major criteria, then you need three of these minor criteria. So you might have positive blood culture, you have embolic disease, fever, and some of these Roth spots, but you can't make a positive echocardiogram. So that would be enough to call it infective endocarditis. Or if you have all five of the minor criteria, that works too. So you don't have positive blood cultures for common organisms or a positive echocardiogram, but you have all these other things we listed. Actually, before I go on, one of the reasons why this is important, the reason that we need these Duke criteria, is because it's going to make a difference in treatment. So keep this in mind when we get to the treatment page. So we think about drug users and rheumatic fever as the main populations that get infective endocarditis. They're, of course, not the only populations that get it, but they are some of the most common. Rheumatic fever is declining in the population, so we're going to be seeing less of that, especially as we get into practice later on. But the drug users, I'm sure we will keep seeing. And the major organisms that you see are Staph aureus, which you're going to get from the skin, obviously. Strep viridans, which you get from the mouth, and other strep species, many of them from the skin, as well as Enterococcus. If you have no positive blood cultures, but all of our other Duke criteria suggest we have a endocarditis, then we want to start looking at the Hasek organisms. These are the ones that we don't show up regularly on a culture. They're hard to culture for. So Haemophilus parainfluenza, Actinobacillus, Cardiobacterium, Eikenella, and Kingula kingae. So Eikenella and Kingula kingae both are associated with bites. So if you've been bitten by somebody and think you have endocarditis, please tell your doctor to order workup for Hasek. The drug users that get this, we have Staph aureus. We ought to list Staph epidermidis here. Those are going to go most likely to the tricuspid valve, whereas if we have somebody who had a previous rheumatic fever, they are most likely going to have a damaged mitral valve. So on the right side of the heart, we're going to be thinking about drug users. On the left side, we're going to be thinking more about rheumatic fever. There's also non-bacterial endocarditis, so that includes lupus and cancer and some others, including foreign bodies. But they have a little bit different appearance, at least on autopsy. I don't know if you can tell the difference on an echo or not. But lupus causes the Liebman-Sachs endocarditis. And cancer, you can have metastasis that goes to the valves. And that can be a scary one too, because it throws off metastatic emboli all through the body. So we mentioned that it was important to know if this was endocarditis or not. So we have a positive blood culture, and we're trying to know if this is endocarditis or just a blood infection. And that makes a difference in how long we're going to treat it. So if we do meet the Duke criteria, then we're going to do 4 to 6 weeks of antibiotics. If we don't know what the organism is, we're going to do vancomycin plus ceftriaxone or vancomycin plus gentamicin. And if you have a kidney patient, substitute daptomycin for vancomycin. In what I've seen in my limited experience, the vancomycin often precipitates a kidney problem pretty quickly, and so most of the patients that I've seen with infective endocarditis were switched from vanco to dapto after their kidneys went out. Of course, we can also get the sensitivities back and treat based on the sensitivities. So we're going to be causing some serious damage to these valves the longer we let the organisms grow on them. But you also don't want to go in and do surgery if somebody's got an infection. You don't want to do surgery on an infected area and let that spread everywhere else that you might be putting your hands. So there are some criteria that are used to decide whether or not you'll do surgery on them. These were given to me by an infectious disease doctor, and it sounds like surgeons have a little bit different criteria, but according to infectious disease in general, if you're given an appropriate therapy and the endocarditis is not improving over a 4 to 6 weeks treatment, then that's a good time to go in and cut it out. If the patient is in heart failure because of their valvular disease caused by the endocarditis, then you got to go in and repair the valve. And if they're throwing off multiple septic emboli, then you'll want to go in and cut it out so we don't get strokes and ischemic bowels and etc. And I think the surgeons would, in many cases, add on one more criteria, that if you have a big enough goober, as I've heard them call it, on the valve, then you go in and cut it out. I don't know how big it has to be in order for them to go in and cut it out, but I think I've heard that if it's over 5 millimeters or over 10 millimeters, they'll go in and do surgery. So the images that I used here were from Wikimedia Commons. So they have a Creative Commons license on them if you need to use them for something else. And please send me some comments on the videos so I know how to make them better. I appreciate everybody who's been watching them. But please let me know if there's important information I'm leaving off, or if I've made some errors, and we'll try and make these videos better in the future. Thank you.